I was not here. Did anybody win the drawing for the year's supply of medical marijuana? You mean that hadn't been done yet?
You still have a chance.
Okay.
First of all, I want to really thank Kate Norris and Christian Nye, and I would like to... They and everyone from the American Cancer Society, this conference couldn't have happened without you guys. It's just been great. Thank you. But the other thing is, I thought Janice and I, before we started answering questions, would just sort of focus back a little bit on Montana and what we do. And so I'm going to talk you heard a little bit about what I do in my practice, but I thought I'd describe the climate in Bozeman in terms of pain management. I'm very, very lucky to have, in my internal medicine practice, another internist and a couple of non-physician providers who are willing to take patients who have persistent pain and work very closely with them. We are all pressed by time, we're all pressed by documentation issues, and we're also pressed by knowledge issues and making sure that we're up to date on everything that's going on. So we do not have, we have 3 interventionalists in the community that are helpful, but are interventionalists. No offense, Brad, if you're here, but you know they have their needles. We do have some access to some clinical social workers, and we do have also in our practice, luckily, we have a nurse practitioner who's a psychologist, and so she's been extraordinarily helpful to us. So slowly we've been building some resources. We also, in Bozeman, for inpatient stuff, have a palliative care program that has been really helpful in terms of dealing with some pain issues on the inpatient side, so that's been helpful. But we're still struggling. It's a constant issue, and I'm constantly trying to figure out how to best get these patients taken care of in not so much 7.5 minutes, but more like 15 minutes to 30 minutes. We are under the gun in terms of productivity. I think I mentioned that before, and that's constantly an issue for us. And another concern for me in my community is, one, getting the primary care physicians interested in this, one, and two, I think, as I said on that first day, pain as a quality issue has never come up in any of the quality meetings that I've attended, and getting that to really be on the agenda as a real issue has been a problem in the outpatient setting. I'm pleased to say in the inpatient setting, actually, that has been a very strong quality initiative, and starting on Monday, we're going to be training 50 nurses in our setting with the Pain Resource Nurse Program. June is kind enough to do the opening talk for that. Thank you, June. But on an outpatient setting, it's really, really been difficult to get that as a quality initiative.
And is that working? Yeah. I have the absolute luxury of practicing in Missoula, which has 2 pain centers, interdisciplinary and multidisciplinary, and I am that's the only place in the state that has 2. We're lucky if we even have 1 in a couple of the communities. And I have 2. I have access to just about everything I need. I've got all the multidisciplinary things that I talked about in my lecture yesterday. So I get to practice in a very nice situation. I also don't have 7 minutes with a patient. I'm not on any productivity. I mean, I am on productivity. What I make, but no one's over me telling me I only have a few minutes. Most of the rest of the state, the problem usually is not you only have 7 minutes. The problem is, who do I send them to? I don't have anybody to send them to. So rural Montana really doesn't have the luxury I have. They don't have as many different options that they can go to. So it's not as much, I don't have enough time to spend with my patient. It's okay, I've spent all this time with my patient and I know what they need, but I can't get them to there. I can't let a chronic pain patient travel 100 or 200 miles to get it. Last year, if you were here last year when you heard about the Montana Medicaid program, we had the Nurse First program and we were using a contract company that was using chronic pain as a chronic disease, and we had nurses who were doing a lot of the work and a lot of the referrals. We have moved now in for Montana Medicaid into the Health Improvement Program, which does not have a contract company. We're doing it all through ourselves in the state. The idea of the program is based with health coaches who can be RNs, LPNs, social workers, and these health coaches, we identify the high-risk patients through some predictive modeling, which has been used throughout the country, as to who's going to be high risk. The health coaches will go out to them, identify their needs. The needs could be that they don't have transportation to the doctor's office, that they can't get their medications, they don't have the copay, or because they have an environmental problem that needs to be fixed. Whatever it needs to be done, that's what the health coaches will do. We have these health coaches are all based out of the community health centers and tribal health centers, but they will cover any Medicaid patients who are being seen, even if it's by a private doctor. They still can have the health coach. And pretty much it covers everywhere throughout the state. We have all the patients covered. And the only glitch now is that for some reason CMS, who thought it was a great idea a year ago and a great idea 3 months ago, has all of a sudden decided that, oh, wait, this is new. No one else has ever done this. I don't know if we can do that. So if anybody has any clout with CMS and would like to say, you know, Montana, we only have 1 million patients or 1 million people here. Can't we try something new in this state, even if you haven't tried it somewhere else with Medicaid? But that's my editorial comment.
Okay, we're going to do a few things. I've got some questions from yesterday, and and then I'm going to ask a few of these because some of them group together, and then we'll take some questions from the audience. First, I wanted to ask Dr. Turk. Dr. Turk, you mentioned lobotomy yesterday. This morning, right. Do we have any evidence that pain care improves if the pain care providers are lobotomized?
I don't know if I can comment on that. I do have a cartoon I sometimes show about, I'm in the Department of Anesthesiology, about nerve blocks and a strong emphasis on the conscientious injectors.
One question that did come in that I think we've not covered at all in this whole conference, and that is the effect of pain. Chronic pain is a disease on the physiologic systems. And this question is basically very simple. How does pain affect the immune system? So anybody want to tackle that one?
Dennis.
I do. I mean, does anybody have any data on how pain affects the immune system?
I was the one that actually had made a comment about that, which was John Libeskind, who was from UCLA, the pain center in UCLA, and he had data related to the immune system and suppression of the immune system. Opioids will suppress the immune system, but chronic pain also suppresses the immune system, and there's an incidence of higher URI, upper respiratory tract infection type of illness that have been found related to that. I want to point out there's also imaging brain with our functional MRI scanners that are available now, that chronic low back pain causes some fairly dramatic volume losses in the brain. So when you say chronic pain isn't a chronic disease, it has the hallmarks of chronic illness in multiple areas, including demonstrable brain loss, volume loss, which is a big deal. And we don't even know that if a patient recovers, so you have somebody with 20 years of chronic pain and then they do better, will their brains recover function the way it was before? And probably has to do with a lot of factors, not just the pain itself. But it's an interesting physiologic phenomenon. I do not know what type, is it cell-mediated immunity? Is it IgG, IgM? I don't know that specifically.
Bill, I just want to add that to that.
Only 1 year overdue, Jennifer.
If you're gonna make a cute comment, you gotta yell it.
We keep all the cute comments here, it's the general.
It's a general comment.
One of the other questions there were several blocks of, and that is the whole role of PTSD and trauma, either remote or acute, in treating pain. And a corollary to that question is really some more information about EMDR. Sort of how do how effective is that? Is that the primary treatment for PTSD symptoms? And just some comments about PTSD in the context of chronic pain.
I'm sorry, we're using a lot of initials, and EMDR, maybe I'm the only one who doesn't know what that is, but.
Dave, is Dave around here? I'm not sure what, I'm not sure what the letter stands for, if anybody does.
I think it's eye movement desensitization
Okay.
and reprocessing.
And reprocessing.
Thank you.
So does anybody have, I guess it's a two-part question. So one question is really, I think all of us that deal with chronic pain recognize the fact that there is a tremendous increased percentage of patients who've had trauma in childhood, whether it's emotional, physical, sexual, some sort of trauma in childhood. And then we see these patients that have had a traumatic event, such as a motor vehicle accident. Then you're 5 months down the road and nobody's really recognized that this person won't drive. The person is getting sweaty when they get into the car. They make their husband drive or whatever, or their wife drive. Tell us about that, if somebody could pick up on that one, and what role that trauma seems to play in chronic pain and maybe how to deal with it.
I'll take a stab at this. First of all, I want to be cautious about the word trauma, and especially when you want to talk about trauma from childhood physical and sexual abuse, because it's all retrospective historical data. And when people have looked back, the evidence is not nearly as clear as you might think that historical trauma actually does lead to PTSD in an adult. So whenever you're asking somebody, back when you were 3, 4, 5 years old, now that you're 38 or 44, do you remember having these? The evidence is not very good, that's really very strong. The prevalence of PTSD in people who have been in motor vehicle collisions is relatively high, because at least based on the research that we're doing. However, how much it contributes to the chronic pain, or how much the chronic pain contributes to that becoming more of a problem for these patients, that's really unclear. There's a lot of information coming out now from troops who have been in the Persian Gulf area with high levels of TBIs and PTSD. So there's a lot of information starting to come out, but I don't think it's very clear at this point. So I think you need to make a distinction between historical, physical, and sexual abuse versus trauma that's identified particular cause. Some of the data I was showing you about the fibromyalgia patients and trauma, I did it very quickly. I'll just remind you what I said, which was if we took patients who said their symptoms began following from a trauma, physical trauma, versus those who said that it was more insidious onset, on nothing physical could we identify any different among those two groups. But the patients who said that their symptoms were caused by a trauma rated themselves as being more impaired, more disabled, more depressed, and it's as if they interpreted themselves as, and we wrote a paper about this called having been injured, the fact that I've been injured. So we can talk about the physical basis, and we can also talk about the interpretation of trauma. So I think it's important to understand and to know that about people, whether they've been involved in a trauma, but I do think it's important to keep those two types of trauma separate.
Could I ask a question? Are you hearing me? Dennis, that's the second question. Yeah, I did again. So if trauma plays a role in some of the symptoms, does how important?
Yeah, cut out.
How important is it, Dennis, that we actually address that post-traumatic stress, whatever it be? Can a patient get better without addressing it? Because a lot of times, especially in my field, we don't really identify it that was going on. So we're treating the pain with medicine, we're rehabilitating the patient, but we don't get to the underlying maybe post-traumatic stress disorder. How important is it to identify it and treat that to the rehabilitation of the patient?
Had a simple answer to that. We really just don't know. One would expect that depends upon the kind of treatment we're talking about. If you're trying to put a patient into a rehabilitation type of treatment and you expect them to do physical therapy and things of that kind, you're expecting them to do a lot on their own. I could see it would get in the way of them being willing and able to do that. If I'm upset and distressed and you tell me just do some exercise, well, you haven't dealt with the fact I'm upset and distressed. I don't know how it would play out with medications. I don't know how it will play out with nerve blocks, other interventions.
Have studies been done of people with PTSD to examine whether there's an altered sensitivity to a painful stimulus?
I don't know. Doesn't mean there hasn't been. I just don't know if there has.
I thought I read something, but it was one of those skimming things where there was a report of altered responsiveness to experimental pain stimuli. But I don't know if anybody is aware of that, because I'm really confounded as to how you deal with folks. Is there,
Is I just had my candidacy exam, and that was one of my questions. It was hard. I'm doing a study on resilience, and they asked me about the biological mechanisms of resilience. The only place I could find evidence that there are changes, as we talked about the pain process where you go from transduction to transmission to the brain for perception and then back for modulation. The PTSD folks have found that there are differences in the modulation pathways in people with PTSD. And that connected for me, sorry, but that fits with the resilience piece because I'm seeing that modulation probably ties into resilience. So that's how I made that connection in my exam. But the PTSD folks are doing great research on this, and I think that they will show us there's problems with serotonin, there's problems with norepinephrine. Neuropeptide Y is another one. The people who have PTSD don't have that, and that's helpful for bouncing back or recovering from pain and difficulty. So they're starting to do that.
Anybody have any information on EMDR in terms of treatment?
I am an EMDR trained therapist, and there's been a lot of study on the eye movement desensitization reprocessing therapy for trauma. It works well, but you also have to be very careful when you're doing that because it depends on the types of trauma, and it depends on if it's a childhood trauma that someone has been has been abused long-term, has severe dissociative problems or anything like that. It takes a lot longer. Some of the short-term trauma, like a car accident, you can use the EMDR, and sometimes they're fine within 1 or 2 sessions. But it just depends on the individual. And you also, one of the comments I would like to make on all the comments that have been made thus far is that it needs to be a biopsychosocial spiritual model with dealing with clients, because some clients who have experienced severe PTSD or trauma as children aren't ready necessarily to deal with their trauma when you diagnose them with pain. And so beginning to work with those clients and kind of discern what's been going on over time, you can do that. But there's a lot of therapies that work. Some of my clients do not want to do EMDR. They're kind of afraid of it. They don't understand it. And we do other types of therapy. And there's a lot of different therapies that work. One of the main therapies that I have found works well, and it's a cognitive behavioral model, is a dialectical behavioral therapy skills training. My clients who have chronic pain, who have difficulty coping, those are skills that they can use to cope with life's issues, about how to deal with their children, about how to deal with their boss or with their doctor, how to communicate with people, etc. And that seems to be a really good way to start developing a rapport with people and actually have them do something that works for them in the moment, versus a long-term therapy with working on childhood abuse, although I think all of those things need to be addressed with that individual.
Thank you. Anybody else have a question from the audience? Wait for a microphone if you would, right there behind you.
Yeah, I've got some friends in the naturopathic community, and they talked about a technique that's similar to EMDR, but actually they claim to have a higher success rate. It's called EFT, emotional freedom techniques. And the thing with EMDR, my best friend from high school, he's now runs the business school at Texas Tech, so he's not somebody who's a flake. He completely says that it changed his life from his emotional traumas, and so it's something that I recommend to all the patients. But EFT is something that people might want to check into if EMDR is something that doesn't work, or just as an adjunct.
Okay. All right, any questions for any of the panel members from the audience?
Now that Ethan's spoken, I found out that what I actually did in North Idaho song.
Click that top button. I think that's a mute thing, maybe. Click it up.
Is this better?
No.
Ethan's convinced me that what I did with 400 chronic pain patients in North Idaho was get quirky. So I appreciate having that finally defined for me, since among that patient population were a significant number of addicts, which is why I can ask the next question. I want anybody on the panel to tell me, if they're serving as a defense medical expert witness, how you would respond to the government's charge that the use of opioids in any amount is essentially unnecessary because pain is not an opioid deficiency. That was stated by the medical expert, okay, serving the government's case, when he spoke to this, unsophisticated jury about the reasons why we have a problem as prescribers in this country, because we have misconceived pain as an opioid deficiency.
Okay, lawyer. I'm going to answer that because I know a lot about what he's talking about. That was a problem with a particular government expert, and that problem has been
Eliminated?
I actually worked well behind the scenes on that because I didn't want the particular government expert to know, but between myself and another lawyer, we took care of the issue. The real, well, no, Chris knows what I'm talking about. The whole way that expert talks and testifies is very contrary to how he practices. And that's something that you must always remember if you face any expert in any kind of legal capacity, is that you need to talk to your lawyer about the differences between your realities in pain management and who you encounter and the realities that expert may conjure up on the witness stand. And that is a matter of expert ethics. It's a matter of proper, lawyering and understanding the issues. And without disclosing too much more detail, it's an effort that a couple of us across the country and some lawyers, friends of mine, are trying to take care of, is to get these crazy theories out of the courtroom and put the playing field back so that when somebody is a defendant in a case, whether it be criminal or administrative, that we are dealing with the standards of care based on what happened at the time, like 1999 or 2001 or 2003, and not somebody's hocus pocus opinion for what might be happening now. And so it does really make a difference. What he's raising is a real important issue, and it's not so much about the government's expert, it's about their mentality. The government stays in the past when it looks at your conduct, but they try to prove it was wrong with today's viewpoints, and that is a very dangerous place to be in litigation.
Can I just add that this reminds me of the definition of an expert. It's someone who knows more and more about less and less until they know everything about nothing.
The other thing I wanted to just quickly address is the fact that as much as, obviously I believe that chronic pain is something every primary care physician needs to undertake, I think we give a short shrift to the fact that anxiety, which is a different physiological mechanism, and sleep disorder, these three common comorbidities, play this fascinating game such that as we're attempting to modify any one of those three, we find ourselves frequently, when we talk about the amount of time we have to devote to these patients, to some extent, I think if we don't identify those comorbidities as equally important to the patient, because I've become convinced clinically, I wasn't taught that anxiety is every bit as intolerable as pain, and for some people is far more the reason they end up on opioids even, and that sleep disorders are so intolerable that they have everything to do with why the other two problems present. And as we spend our time talking about chronic pain, if we're not including those other two, I think we lose some of the benefit that we're going to be giving our patients and that we're going to transmit among one another by recognizing we've got to deal with the trio or we're going to come up short.
I just want to comment that one of the problems that I have in my practice is sort of chicken or the egg and which is doing which. Not sleeping can cause anxiety, can cause pain. Pain can cause not sleeping and anxiety, or they may be, three separate problems. And sorting that out it can be a real issue.
I want to just take a contrary point of view. We know that if you, when studies have been done to look at like fibromyalgia patients who we know have a sleep disorder, and you give them a drug that it doesn't cure the sleep disorder, but it gets to the stage 4 sleep, like Ambien it works very effectively at stage 4 sleep. And then you study the patient afterwards where they say, yeah, I slept better. Their tender points are the same, their dysfunction's the same, their distress is the same. And if you look at anti-anxiety drug, all the benzos, and you look at all the sleeping pills we give people, even if they sleep better, I agree with you that anxiety and sleep is a major problem, but do pain levels go down with benzo treatment for anxiety? They don't go down particularly. So they are comorbidities. They must be addressed. They're very distressing for people, and sometimes treating the sleep disorder with an antidepressant makes a big difference in patients' quality of life. But when you study this in a blinded fashion, looking just at sleep or anxiety, and you just treat that, the pain doesn't seem to get better very much. So there must be something else going on other than those two comorbidities.
Grab a mic. Perfect.
Just to comment, I may have shared with some people here, I'm boarded in sleep, and so just to answer your question, there is actually literature in the sleep medicine that answers your question, which came first. Actually, what comes first is the insomnia. Insomnia is increasingly recognized by our psychiatric colleagues as the first symptom of depression or anxiety to present, and the last symptom to go away with treatment. And our psychiatric colleagues are because of that data, starting to treat insomnia a lot more aggressively. And then from the sleep perspective, not a lot of patients, but I have had probably about 10 patients over the years. Young, healthy women, fairly thin, they don't have the classic body build, but they ended up having obstructive sleep disordered breathing. And once I got them on CPAP, they came off all of their opiates, and they did have complete resolution of pain. Is that the majority of patients with fibromyalgia? No, it's not. But I can tell you I've had complete treatment and remission of pain. One of these patients was unemployed on chronic opiates for many years, and I treated her with CPAP. And then she came to work for our sleep clinic, and she was the head sleep technician. So she had been unemployed and on opiates for her fibromyalgia for many years. And then when she got treatment, her pain completely resolved, and she did go back to work. So it is possible.
While you're talking about sleep, you want to make some comments about the whole effect of opiates on central sleep apnea and the risk and how we should deal with the patients. That patient that we say, well, your pain's keeping you awake, we're going to give you some opiates and it's going to make the pain better and you're going to sleep better, and they get worse and worse. What should we be doing with those patients?
Well, the one thing that you need to be really aware of those patients is we all have patients that have died on opiates, and the majority of patients who that I've spoken to at the corner on it, I've been informed that they usually have sleep apnea as a comorbidity. So sleep apnea is a risk factor for death as an outcome for treating as opiates. Usually it's in combination with alcohol and other medications is what's fairly classic. You should probably be aware of sleep apnea in your patient population. And the one thing I try to teach physicians about sleep apnea is the idea of a middle-aged or older obese male is to sleep apnea as a gay man is to HIV. We recognize the disease in that patient population. Great. They have severe disease. But you can see sleep apnea in childhood, and you can see sleep apnea in thin women, and it's a different disease in your different patient populations.
Are those patients showing up with Herculean snoring if they're not central sleep apnea the way we'd expect?
I'll tell you, most women that have sleep apnea that I see present in my clinic with one of two symptoms: insomnia or fibromyalgia.
So we couldn't tell by a bed partner is what you're saying?
No, most women, if a woman snores, I believe her risk of sleep apnea is probably about 70–80%. I don't have data to support that. But most women that have sleep apnea actually come to the clinic with a chief complaint of either insomnia or fibromyalgia or chronic headaches. And I find it as a sleep doc because I do a polysomnography as a part of my workup if they become a chronic patient, whatever that means. To me, that means if it's headaches, they've tried and failed 3 prophylactic medications. At that point, if I'm looking at refractory long-term chronic headaches, I'll do a polysomnography. On my back patients, I treat the insomnia, and the sleep doctors always say don't do a polysomnography as part of an evaluation of insomnia, and that's true when you first see them. But if you've treated them for insomnia and they've failed 2 or 3 hypnotics and they're not sleeping, you probably ought to get a sleep study. So that's my insomnia is what you're going to see as a pain doctor as a presentation of sleep apnea.
Do you have any guidelines in terms of patients on long-acting opiates like methadone that you're treating? When would you begin to worry about those patients? You're escalating doses. When would you recommend that physicians or anybody who's taking care of them refer those patients to a sleep doctor?
From the pain realm and chronic opiates, I believe you should strongly consider getting a polysomnography on anybody that has any neurologic condition, because all of the neurologic conditions, stroke, anything, they're all associated with increased risk. Anybody that's had neck surgery, that's a proven risk for sleep apnea, those kind of things, and if they have a sleep complaint. So if they're coming to your clinic, you're treating for chronic pain, and they have refractory insomnia, that's when you need to think about it. And also if they're drowsy, don't assume that their drowsiness is from their opiate, because usually it's comorbid. You know, they've got sleep apnea, you give them an opiate and you made the sleep apnea worse.
Right. Yes.
One thing I've done is just refer the people to a home oxygen drill for an overnight in-home screening oximetry. It's fairly cheap. It's fairly cheap and simple to do, and if they well, when the people who are on the chronic opiates have the local home oxygen company go out and set them up with an overnight in-home screening oximetry study. And if they flunk that, then they go see Dr. Mulgrew.
And they can do that without a big cost?
Yeah. Some of them, sometimes it can be free. It's maybe $85, $100. And insurance will usually pay for that.
Really careful with that, because I've seen if it's abnormal, you're fine, but if it's normal or they only have 5 or 6 apneas on there, be really careful with a normal overnight polysomnography, especially in relatively young, relatively healthy patients like the young woman with fibromyalgia. You'll get fooled by that time and time again. And I've seen it many times as a sleep doctor. It's a great screening test, and I don't discourage its use. I would just say if it's a normal overnight pulse oximetry, but you have a patient that's drowsy and they have insomnia, don't assume that they don't have sleep apnea. That's all.
I would second that because I used to do that, and then they'd be normal, but I still had suspicions, and I'd send them on for the test, and then their insurance would not cover it because I had a normal overnight oximetry. And not all sleep apneics have hypoxia, so they're not all going to show up on that overnight oximetry.
I wanted to thank Ethan for coming to Montana, and I appreciate the history and what's going on and all the rest. I would like you to provide at least 3 things or 3 suggestions that people could do to try and make some changes in our policy and our legislation besides donating to your foundation.
God, I didn't even mention the donation part. I'm glad you suggested that. Just go to drugpolicy.org and make your contribution. 3 things to do. Well, I think some of these things I probably said during my presentation. I think the first one, and it's kind of it gets both generic and specific, which is just to the extent that you're not properly informed about some of these things, to the extent you find yourself saying, I don't prescribe that or I don't do that, like in the case of marijuana, for example, to just read the literature and find out what's going on, what's going on there, and so that you can do that and that you're, doing right by the patient. I think secondly, I think it's for a group like this. I mean, it's an impressive group right here, and you are physicians and you have standing. And we know that when the AMA is out there fighting for the financial benefits of doctors, they can be a fairly forceful, organization, whether it's dealing with national health care debate or whatever. But, collectively, you can also exert political power if you choose to do so. It is not inevitably the case that, well, we can't do that because the federal law says that or the state law says that or whatever. If, in fact, you see things that are in state or federal legislation that are standing in the way of effective medical practice, and you must see that, well, this organization can, in fact, say, here is our list of legislative changes that are required in order for us to practice effective medicine. And you can build coalitions with other pain docs around the country, and you can sit down with your members of Congress and the members of the state legislature and say, these are the changes that we need. And in some cases, these changes have been made in other states. In some cases, they've been made in other countries. But it is to operate in that way. And then the third thing I would say, and this I know is not going to be a very fulfilling answer, but somebody sent me a note, just asking, says, allowing patients to be self-determined in regard to what substances or chemicals they put in their body is all well and good, but what we know about addicts is they seek more of the substance to achieve euphoric effects. This can often lead to OD or death. Primary care doctors are often implicated in these situations. How does a primary care doc or provider draw the line between being part of the solution and being accused or seen as part of the problem? Now, I would say 2 things. I think the first thing is in our understanding of the addict, just understand from how much I've seen about addicts, of course, this line between being in pain and being normal and euphoric is a very, very fuzzy line. And we also know that when you give a medication and you go from being in pain to not feeling pain, that's an incredible feeling of euphoria, right? I mean, so euphoria is kind of all relative in this way. And what I also know, and having sat with people who were addicted to heroin for long times and watched them inject and asked them how they feel, they said, I just feel like the kind of tension, the butterfly's quieting. I'm not getting euphoric anymore, maybe in the initial days. And we also know from people going, for example, to the heroin maintenance clinics, that when they first came in and realized they'd get as much as they wanted more and more. And then after a little while, they wanted less and less because they realized they weren't getting the buzz they wanted. So some of the first thing is to understand there's a lot of myths about what we identify as the addict, and that what determines addict behavior is shaped to some extent by the frame you're seeing in them, which is determined by the legal environment. I'm not in your shoes, and I can't speak to it in that. So all I can say as an outsider and trying to imagine and projecting how I would handle it, when you're dealing with somebody and they're coming in there and you don't know if they're scamming you for a prescription for whether it's marijuana or opioids, whatever, I guess my impulse, and I don't know how much you can actually do this, is to simply make the conversation as absolutely honest as possible. And my guess is that the way to do it, as one does in a lot of other situations in human relations, is to basically almost start off by saying, look, what do you want? Because the odds are I can give you what you want in terms of a script. And you need to be responsible for what I give you if you give you what you want. If you're going to get the same thing from 4 or 5 other doctors, if you're going to be selling on the street, you're going to be responsible for your overdosing or other people or the cops busting you, whatever. But now that we've resolved that, let's have a very honest conversation about what's really going on. The more, and this is, by the way, the same thing's true of education, drug education with adolescents. When you get adolescents in a situation where they can really have an honest conversation about what they're doing and their friends are doing and the situations they're confronted with and actually the drugs they've been trying, and they want to know, what if I combine this with that? And if all the system's offering them is DARE programs and Just Say No, and there's no room for another conversation about the reality of what's going on, then we're not serving our kids well, and we're not making them safer. And we're just saying, if you don't get the Just Say No message and you start to experiment, then the hell with you. We don't care what happens to you, which is not true, because we all care about what happens to our kids. So that honesty in that room, and I think that finding the ways to create an atmosphere of the greatest possible openness and honesty in that conversation, whether or not that patient's coming in what you see as a scam, and it's a scam created by the legal context, right? You don't need to participate in that scam in the sense that you can say, okay, you give me any kind of valid reason for why you need this. Here's the script. Now let's talk. I hope that helps.
And then call me.
He's trying to drum up business.
Let's see if this works. Hi. I'm now in the practice of addiction medicine full time. And during the last bunch of time, I've had various jobs. And I'm going to bring up a nasty topic, a nasty one, and that is incest. We're talking about PTSD, and we're going to have to allow just a little bit of space for the fact that we don't treat our kids very well. While I was the medical director at the Montana Chemical Dependency Center up in Butte, I did the unthinkable. I deviated from the standard question protocol, and I asked people coming in, have you ever been sexually abused? I asked it of men and I asked it of women. The women had a much higher response rate, probably 80%. The guys, maybe 50%. I don't know. I know. And it made my heart bleed. It wasn't just, with my daddy in the attic. These were stylized, ritualized, incestuous, life-enduring practices that these kids were endured, sometimes with the women of the family watching. Good Lord, I know. And so when I left work that day, I wouldn't just go home and think, well, I wonder what I'm going to do about their substance abuse, and I wonder what we're going to do about teaching them the 12 steps, and I wonder if they're going to get it. I was tormented by why we couldn't address this. I was told, oh, well, they're just here for substance abuse. We're not going to address this. This is another issue. They'll have to get that taken care of when they go home. Bullshit. There really aren't any therapists who are available in the numbers that are needed. And so this need usually went unaddressed by women therapists who had some other agenda. And I submit to you that as long as we're talking about PTSD and so we really know about the biopsychosocial model, one of the things that we're not asking the people who are in our waiting rooms in a pain clinic or in a substance abuse clinic is about sexual trauma. And I have a feeling that that's the burr under the saddle with a great many of them, and that needs to be part of the dialogue.
I think it actually is part of the questioning on one of the risk assessment questionnaires, self-administered, the opioid risk tool has that as part of it, if I'm not mistaken. So,
every patient that comes through the Spine Center is asked that question, and I am astounded at the percentage that will answer yes. And what astounds me is that I know I'm only getting a fraction. Even though the percentage is astounding, it's not the whole percentage.
Yeah, and EMDR, by the way, EMDR can be very helpful with that issue, and it helps people move beyond the trauma in an incredible way. It's very effective.
Well, I guess after dealing with this population more and more, and I adopt more and more the notion of, we see a lot of folks we label as people that are misusing their opiates or misusing their medications. My term is they're just trying to quell the voices in their head. Most of the folks that we see are misusing them not because of addiction. It's all the things we've talked about. It's the anxiety. It's the trauma. It's the things that they're looking for anything that will essentially reduce some of the distress. And they'll opiates are a blunt instrument. They do a pretty good job of doing it for a while. But yes, absolutely. And it's really the issue that we see, and we're trying to sort of find a way to deal with it in Missoula, is this whole notion of how to coordinate the mental health care with the pain care, with the substance care, so that you really identify the core issue and really figure out what's at the heart of some of these things.
Randy, I agree with you. It's terrible. I asked the question. I was always asking the females. I asked the male, I got a yes. The next question, which is even more tragic, is, has anyone ever asked you that question before? And they say, no. And it's with pain, when there's something in the back of your head it doesn't make sense. And I preface it by saying, I have to ask this question because there is a correlation between chronic pain syndromes and sexual and physical abuse. And I need to ask you, have you ever been? I don't need to know the details. I also want to know when, because I think in the developmental stages of the nervous system, there's a big thing with the activation of the hypothalamic pituitary adrenal axis that persists even after the abuse has stopped. And these people are just waiting then for some little perturbation of the nervous system to kick them over.
Right.
And those are the people, I just stubbed my ankle, and you wind up with Crips or some other pain complaint. But it's something that we all have to be aware of.
Well, let me put another spin on it, and that's, I was having a discussion one time with a pain provider who said, this person read me the whole history, and we were sitting at a meeting, and this person had a history of sexual abuse and had come in, and the person was ready to fire the person because she had been prescribing opiates for a couple of months, and finally recognized that the patient had not told her the truth about something. I forget what it was. It was her medications or anything. And finally confided, said, okay, yeah, I'm going to tell you, this is what's going on. I'm smoking marijuana or something. And the provider said, well, you broke your contract. If we can't have a trust relationship, I'm no longer going to be your physician. And you look at her and you say, this person has had the most inviolate relationship violated. And you think that because you're a physician, she's going to immediately in 2 months sort of say, I'm just going to trust you right out of the bag and lay it all out on the line for you and let you have full control of my future. That's not going to fly. So I think we have to realize that the behavior that we're seeing has to be interpreted within a whole different context that we're not used to dealing with completely.
And the power we have as providers. I mean, we have
Yeah.
huge power. And how that plays into the relationship we don't know.
Then on that, because I think that when I was talking about documentation and whenever I write and teach on this, all of the points that are being made about, dealing with people that are, I guess, giving some indication of aberrant behavior relating to their drugs, if you explain what you're doing and the time that you're taking to ease somebody into a proper treatment channel or to try to get them back in within boundaries, that goes a long way in the courtroom. It goes a long way, like if you have somebody that's smoking marijuana because they've suffered incest and they're dealing with all these issues in their brain. I mean, I think it's inhumane to cut people off like that without an explanation, yet I know we have to operate within the boundaries that we have right now. So you can explain your rationale for giving the individual additional chances, for, I'm not going to cut the opioids off right now, I'm going to maybe take a little more control in the amount that I prescribe or the type of drug, or we're going to get the counseling, we're going to spend a little more time in here and there. that's usually missing from documentation, which is why people end up in trouble. It's more that than it is anything else. And, you know, at the center of all the legal problems is usually another clinician. And your role isn't to convince that other clinician that you're right about the decision you made. It's that you wrote down your reasoning and that you gave a good faith attempt to comply. And you can't control all these behaviors and things. So you really have to get those nuances from the person that practices law actively and understand that you can advocate for your patients and you can say we need more of this and more of that, but you have to kind of play the game here the right way.
Sometimes when I see the patients and I know they're holding back, but they won't talk with me, I usually will preface it with, you know, how honest you are with me will help me treat you. And if you are holding back on something, that will limit my ability to treat you. So I'm going to treat you with the knowledge I have. But if things come to light later that I realize that that was unsafe in how I treated you, I'm going to pull back. And you're just going to have to understand that. And I will. I'll be more restrictive. I'll have them come in on a weekly basis. I'll do whatever. But I usually won't fire them the first or second time. I will fire them the third time if I can't feel safe. And I don't always fire because I'm a family doctor. I just say, I don't feel safe prescribing this particular medication. I'll continue to be your primary care provider and continue on with these problems. But right now, because you choose to withhold information or you choose to go to the ER or go to another provider and not tell me about these other medications, I don't feel safe giving you that medication.
Not say anywhere that you have to fire your patients. Okay? And that's really important to remember because we take it is to listening, well, I've got this one strike and you're out rule, and that's how some person gets up here and explains it from a podium. That's not what it says. It says that you have to take care and reasonable steps as part of your routine medical practice to guard against abuse and diversion. And that has a very wide interpretation. So what you just described as a taking control, honest discussion, patient has responsibility, really trying to work it the right way is what is expected. And when you have all these complicating factors of these horrible histories, remember that the people that you're explaining it to are also human beings, and when they can see that you took the time to do that with somebody, that clicks in their head because that's what they want their own clinicians to do. And so that's really how, theoretically, you would go about documenting it, and it is much more effective that way in hearings and courtrooms.
I agree with documentation, but there's a point. In the Hippocratic Oath, it states, I will go into the house of men, and if I find something that should not be spoken of, I will not do that. What do you do when your patients invoke the seal of confession?
What do you do with what?
They say they don't want you to put it in the record. What do you do?
Well, I actually tell them that the record is for me to take care of them and my partners to take care of them, and that I'm not documenting or doing anything according to the legal system. I'm there to take care of them, and it has to go on the record because my memory isn't good enough if it's not written down. And if they're uncomfortable with that, they need to pick a different provider.
You know, these medical records are open, we're comp records. I mean, that's one thing. They're so open. That's the problem I deal with.
I agree with you. I know that's a problem, but I can't do it any other way in my practice. I have to be able to take care of the patient, and I regard the record as a communication between me and my partners and myself when I have to remember something a year from now. And so it may be cryptic. I mean, I know what I mean when I say something.
Again, I think this is this legal thing that we talk about, personal rights and how much is available and what we as physicians, healers, have to divulge on people.
When I was a prosecutor, I used to have to give over my records if I did something, to the defense counsel. You can't hear this because someone else is on. But at any rate, I used to learn to draw pictures and things that would help me remember without labeling anything. And you have to, things have to be written down. but you don't have to label or give opinions about it, and you don't have to, be overly blunt about it unless there's a reason to, and that's within your discretion. But it is subject to what your ethics codes are and what your medical record keeping codes are. And I can't control the privacy issues. I can only say if you have a problem with it, you need to raise the issue, but certainly front all of that with the patients and make them understand that it is for you and not for the government that you're doing this.
I think, excuse me, one of the things I know that I've come up against as a licensed clinical social worker and as an LAC is the diagnosis. And when I was working in agency settings, that were specifically treated, where the treatment agenda was specific to chemical dependency treatment, of course, everybody would have a substance use diagnosis. In my private practice, however, because of concerns about, with insurance companies asking for records, I have gone the other direction and have really relied heavily on adjustment disorder diagnoses, which are still relevant because most people do have depression, anxiety issues, and so it's going to be adjustment disorder with the depression, anxiety issues. But I do not do the substance use diagnosis because people do lose coverage. So, and I don't know how other people who are in pain clinics deal with that, that diagnostic piece. And I guess that's a question I have too.
Well, I would think that it depends on what your diagnosis is. When you have a diagnosis of diabetes and they have retinopathy and peripheral vascular disease and things like that, you often code diabetes because that's the cause of it. So substance abuse may not be the cause of their depression, anxiety. It could be their depression or anxiety or adjustment disorder that caused them not to get adequate treatment, and therefore that's why they have a substance abuse. So if that's a true diagnosis, it's an appropriate diagnosis.
That's kind of touching it.
Well, there's another aspect of that too. The bigger aspect is like that laboratory thing that I brought up. One of the fraudulent issues there, or abusive instances, were laboratories going around and teaching providers to code a diagnosis code that's 304 with extensions that's for substance use disorders in order to get paid when they were performing tests on their pain patients. And I actually had a provider do that to me, and it had a huge impact on my insurance, and I went ballistic. I don't have that history. I know why this happened. I know where you learned it from, and it's wrong. And yes, the provider has a duty to look up and get the right diagnosis codes, but you raise a very valid point. You are giving some sort of a label when you use that. And if it's appropriate for the diagnosis, then that's part of our system. If it's being manipulated at all for getting payment, that's a whole nother ballgame. And I know that the government will investigate that. Advocate against it. So be really careful when you pick that stuff and really learn more about it, and don't learn about it from, the marketing materials that come along with whatever treatment or service is being provided. You have to learn about that from professionals that code and understand those issues.
And that is a large issue for the primary care provider, because now with our electronic medical records, we are doing our coding and we are coming up with the diagnoses. And it's often very difficult to find the appropriate diagnoses, and it becomes an issue of time. And finding that right diagnosis, and if substance abuse is right there, you may inadvertently pick that, not meaning to, but that's because it's right there.
Yes.
I've been a podiatrist for 33 years. I've been an attorney for 20 years. You have to remember, as an attorney, we have attorney-client privilege with our clients. But as a physician or a practicing healthcare provider, you have to be careful what you put in your records sometimes. And sometimes there's a lot of non-medical things that are discussed in your office, and they can have a great impact on what happens in a courtroom. So sometimes it's better to underdocument and not overdocument. Use your discretion.
Still going back to the idea that this is a communication device, not a legal device. I don't like to practice according to, it might end up in court. I'm totally opposite of that.
But I'm not so worried about the court as I am about insurance companies. If I put something down about substance abuse and that's really not what the diagnosis is, that's a major issue for insurance.
Any other questions?
That's great.
I've just got one more, having to do with what goes into the medical record. I would explore these issues with the person who's talking to me.
You need to use the mic.
Talk into it? Okay. Thank you. I would explore these issues, face to face, eyeball to eyeball. When I wrote up what we had just talked about, I would put down something very bland. We discussed areas of her childhood that were bothersome. Period. I mean, I don't have to elaborate it to the next yahoo who's going to read that under some other guise, and it could be damaging. My problem was what to do with that knowledge, because I didn't feel equipped to deal with that, particularly with young women, and I couldn't hand them off to the women counselors. They were absolutely refusing of going into those waters, deep waters. And we didn't have much success in placing them with therapists afterwards. I mean, they went back into, the plains of Montana. They went back up to the reservation. They went back to places that didn't give a damn, basically. And to miss an opportunity when we had them for 28 days was just that. It was a missed opportunity. The other thing I wanted to close with, and that is I write a contract with all the people at IC, and I put most of them on Suboxone. I always let them know that the contract that I am signing with them is something very precious, and that I will never change their dose or administratively take them off the drug because they fail in some other area. If they fail to pay their bill, that's for the bookkeeper. And if they fail in some other thing, they don't engage in the IOP, they become late, they don't come to groups, oh my, oh my. But I'm not going to change the medication that we've agreed on until they actually walk away, until they walk out of the office. And I haven't had any problem. And parenthetically, on the back of my business card, I write my home phone number for each of them, and I tell them to call me at any time. I've had one call. They don't abuse that, and I always want to be the first in the loop to know when something goes wrong, not an answering service.
Randy, question for you. First, thank the panel for outstanding discussion. I really appreciate it. Thanks for coming to Montana. This is a Suboxone question sort of posed towards Jennifer. I work in a practice up in Kalispell, and we have a wellness clinic that is focusing more on patient wellness rather than just writing narcotics. And one of these is to get them off their opiates and onto Suboxone. Suboxone requires an X license by a provider. One, why is that? Mid-levels can write prescriptions for Schedule 2 and 3 narcotics, but they can't write for Suboxone. Now, if Suboxone is used for addiction, I can understand that, but if you take a patient and titrate them off their narcotics and put them on Suboxone as an off-label use, does that still require an X license to do that?
A lot of questions there. The whole purpose of that X registration was to give physicians the opportunity to treat addiction in the medical practice and not have to go to a center. And I don't disagree that there are nurse practitioners and physician assistants that are capable of doing that, but for purposes of training and qualification, that's why they limited it for the detox and maintenance aspect of opioid addiction. When you're talking about an off-label use of a medicine, it's really hard as a practicing attorney to sit there and answer your second question, because there may be times when the general guidance would be, yes, you could do that. But then most of the time it's so fact-specific that if I say anything, people are going to hear me say something different, and that could get me in trouble as an attorney. So off-label use of medications is not illegal, but in the area of Suboxone and what you're attempting to do in your wellness center and with the patients, the actual answer is going to be driven on a case-by-case basis, simply because how that prescription looks and really the intent behind it is going to drive the ultimate result. Plus, I would have to go back and double check that there's not some other provision in either federal or state law that would prevent it. And I don't know all that stuff off the top of my head. It's one of those areas where what Ethan brought up would be very relevant in terms of, look, we need to have some flexibility here. Can we get that from our licensing board? Can we get that from the DEA? Everybody will say, again, they're not going to try to stop your off-label use, but that's, in a public forum. But behind the doors, there's a whole different issue and ballgame going on. And it is so, again, I don't know your area, your neck of the woods. There would be a lot to that. So you have to think those things through and see whether it's an area that you can take.
Okay, well, I think we're winding down. Do you guys have anything else that you'd like to say?
I want to bring up an issue. I mentioned very briefly yesterday, and I think it's very important that you recognize there's a September 30th deadline for submitting comments to the Food and Drug Administration about the recommendations that came from an advisory that met on June 29th and 30th. A committee that made a lot of recommendations related to acetaminophen because there is concern that acetaminophen overdoses, legitimate concern, are hepatotoxic. And evidence that it is acetaminophen that is a major cause for liver transplants in this country. The Food and Drug Administration, from my standpoint, did not provide evidence that was strong enough to support removing opioid acetaminophen combinations from the market, for making the 500 milligram dose of acetaminophen prescription only. The committee voted on a total of 10 questions. Some of them make a lot of sense. Changing packaging, changing labeling, lots of things to call attention to the hepatotoxicity of high doses of acetaminophen. But I want you to please take the time to look at this set of recommendations. And the Food and Drug Administration does not always accept the recommendations from their advisory committees, but they often do. And this is something that could have enormous impact on the management of persons with pain in this country. So take some time to do that. The other thing is, Jennifer, you have a copy of Scott Fishman's book here. And again, I want to call the attention of physicians in the room to this book, Responsible Opioid Prescribing. And if you read this book and go online and take an exam that we have provided, that is the Alliance of State Pain Initiatives, you can earn 7.25 CME credits. And that's really a pretty good deal.
That's true for nurse practitioners and physician assistants also in Montana.
In Montana, but not generally, but certainly across the country, we were able to get CME credits for every physician in every state. So if you want to earn some CME credits, make the Drug Enforcement Administration happy, and make yourself more comfortable with prescribing opioids, I strongly recommend this. I can't remember my own website, but all you have to do is to Google Alliance of State Pain Initiatives, and
we'll have a link on the Montana Pain Initiative to it too. I understand. I was just letting people know that we'll also have it on our website, so a link to it. Thanks.
I will put the FDA materials on our intranet too for this thing, so you can get access to it and show you how to make the public comment, because you can do it online through regulations.gov. And I thank June for bringing that up. I had so much to claim, I forgot the most immediate thing.
June, I better ask again. Are you saying that you guys only were approved for physicians?
Yeah, we so far only have approval for physicians. There is interest expressed by the pharmacy profession and by nurse practitioners for them to get credit as well. And they looked at the contents of this book and said that it is appropriate for other professions.
Okay, because we mailed that book out to all of the nurse practitioners and all of the physician assistants as well as the physicians in Montana. And I need to be really clear if that nurses and the physician assistants cannot do CMEs.
We have not got that yet. We have to get some money in order to work with the continuing education department to make that happen. But everyone is interested in making it happen. Hopefully within the next 3 months that can occur.
One more, did you have something to say?
Yes, Ethan, could you summarize the Obama administration's attitude toward the administration of the DEA and whether there will be less or continued persecution of pain physicians?
My sense is I don't see them asserting rapid control over the DEA. I was encouraged recently. There was an issue in the addiction treatment area where physicians who had gotten permission to prescribe buprenorphine for addiction treatment received notices, I think, from DEA, which many thought would have a chilling effect on their practice. And that I just received an email yesterday saying that the head of DEA had met with Tom McClelland, who is deputy drug czar right now, and who had pointed out to her, the head of the DEA, the problems there, and that she was going to correct those. So that suggests, it's one little indication that science-based policy is beginning to assert itself somewhat. And that I'm hopeful. I've seen in the area, in the medical marijuana area, where the Justice Department has taken the lead, and the DEA, it's hard to tell if they're fully complying with that, but I think we're headed in the right direction.
I want to say it's a shell game, and what's happening across the country is the DEA and federal agents are working with state drug task forces, and especially in regions of the country where there are extensive problems with pill mills. Houston, Texas, usually the south part of the country is a big area there. They are taking the information in traditional law enforcement tactics and going through the licensing boards and obtaining more information than they normally would. And there's a lot more behind the scenes prosecutions, either, and that can be any kind, administrative or criminal, that are happening. And there's an upswing of it right now, but you have to understand why. It's not to say that Ethan's wrong, because that's not what I'm saying. There are good points happening, but this cycle of investigations on the criminal arena usually takes between 1 and 2 years to realize themselves, and that's what's happening right now. So there have been a lot more cases filed, a couple in the Southern District of Illinois just this week, and there are many more ethical issues that I am seeing across the country with the behavior of the federal prosecutors or the DEA agents involved, and those are being addressed properly through the Department of Justice. There was a $600,000 plus judgment by the defendant against the federal government. The defendant doctor was acquitted of all charges in southern Florida and filed this inappropriate behavior charge and got the judgment granted. The court found that the government was inappropriate. There have been ethical claims about the holding up of registrations when providers are under investigation, because what most people don't know is that in most DEA offices, the renewal for the DEA registration comes back to the same office that's doing the investigation if DEA diversion is involved. And if that DEA diversion officer has a stake in pending criminal litigation that's actually been filed or something that's under investigation, they usually sit on the renewal and cause all kinds of havoc. I've got 4 cases where that I'm involved with personally where that's happened.
Yeah, and I just should add to that, I mean, I guess the basic point is that there's tremendous inertia behind the old way of doing things. And the DEA is used to be empowered in this thing. But I think there is a moment now politically in Congress and in the administration where mobilization from an alternative perspective, from a health perspective, can actually find some doors opening. So the system that Jennifer's describing can change, I believe, but only if there's active mobilization for an alternative way of doing things. And now would be the time to do that.
All right, well, I think we're going to wrap it up. Kay, Kristen, do you guys want to say anything?
yesterday have been planning this conference for you since January. So we have a committee that is completely dedicated to improving pain management in Montana, and I think you should give them a hand.
Yep. And I guess we would all invite anybody that's here, for the first time or hasn't been involved in the planning or in the task force or anything to contact Kristen or Kay and clearly join up, volunteer. If you've got new ideas, this is a work in progress, so we would welcome your involvement.
Just
So
one last thing. The American Cancer Society and the American Cancer Society Cancer Action Network are the hosts of the PAIN Initiative, and it's our privilege to do that. We do have a listserv for the specifically for the State PAIN Initiative, and what we generally do after these conferences is add all of the participants on there, and if you choose not to be on it, there's a simple click through to take yourself off of that listserv. But we want to make sure that you know that's coming and that you'll be added on if you're not already on there. Thank you.